tell me what the term postpartum means.
After labor.
Okay, after labor. So how long does the postpartum period last?
1 to 4 hours.
Okay, so the immediate postpartum is gonna be 1 to 4 hours. What about how long does it take to get back to normal? Yeah. So usually we consider the postpartum period up to about 6 weeks before you're physically healed, but there's a lot of changes that take a little bit longer. So technically, you're not back to your pre-pregnancy state until about a year after delivery. We consider that postpartum being that first. The vast majority of your questions for your postpartum come from your postpartum assessment. So this is a very misleading slide. So we're going to go through the parts of the postpartum assessment, how frequently we do them, the normals and the abnormals. So you can use the acronym, and it cut off my second E. You can use bubble P as your acronym for your postpartum assessment. If you like acronyms, you can write that fine. Go ahead, fine. The frequency for this assessment is going to be the same as it would be for any other procedure. So when you have somebody come back from surgery, we check them more frequently. It's the same thing for this. So here's the breakdown. You'll do your postpartum assessment Q 15 minutes times an hour, Q 15 times 4, and then you're going to be Q 30 times 2, and then it'll be Q 1 hour times 2, and then it's Q 4. Some of your hospitals will space that after that 24-hour period, some leave it at Q4. So at least for the first 24 hours, the rest of that time frame will be Q4. So Q15 times 4, Q30 times 2, Q1 hour times 2, Q4 hours for the remaining 24 hours. And then whatever the hospital says do. Okay? Now, there's going to be parts of this assessment that you do not do every 15 minutes. So I'm going to go through the whole thing and then I'll tell you which one. You're not going to check somebody's breast every 15 minutes. They're not going to change that quick, I promise. And you're not going to ask if they pee 15 minutes later. But there are some things that we do check for you. So let's go through this top to bottom first, and then carry on. All right, so we are going to assess their breast. Even if they're not breastfeeding, we do need to ask them questions about their breast. So for breastfeeding moms, we need to look at their breast, look at the contour, look at their nipples. Some people have everted nipples, which is much more helpful for breastfeeding than if they have a flat nipple. So there's some tricks that we can do, but we need to know that, okay? You're also going to check their breasts frequently if they're breastfeeding, because you could have some mastitis, you could have some nipple cracking. So we want to make sure that we are spot checking their breast to make sure that everything looks okay. Moving down to your uterus, that is one that you will check very frequently. So we go over what's normal versus abnormal. Normally, before they delivered, their fundus was way up here because they had a baby and a placenta and all this fluid in there. After they deliver, we would expect that their uterus contracts down. So post-delivery, their fundus should now be around the umbilicus. I'm going to say within 1 centimeter of the umbilicus. 1 centimeter above, right at the umbilicus, or 1 centimeter below. It should be midline, and it should be firm. Okay. So the fundus should be at or around the umbilicus, midline, and firm. Those are your normal findings. As the body starts to shrink that uterus down, what is the process in which the uterus shrinks? What's it called? Okay, that's going to be if it's not doing it correctly. So involution is meaning that it's going to contract down like normal. So once we have delivered, our uterus should shrink down by about 1 centimeter per day. And that is a process known as involution. If it's not happening like it's supposed to, that becomes subinvolution. It's not contracting down enough or appropriately. Okay. So let's talk about the abnormals. It should be around the umbilicus, but if it's above 1 centimeter, so 2 centimeters and above the umbilicus, would be abnormal post-delivery. And the opposite of firm is body, because why not? It's body. So a firm fundus feels like a baseball. It's really easy to feel. A squishy or boggy fundus feels like a stress ball or a squish ball. So we like our fundus to be firm, not boggy. And we like it to be midline, not deviated to the the right. It's deviated to the right, that usually indicates a full bladder, and that can definitely increase your bleeding, because it displaces the uterus a little bit. So deviated to the right indicates a full bladder.
Never deviate from that.
Somebody asked me that earlier, I was like, I've never seen one deviate to the left. I'm not gonna say it's not possible, but it is unlikely. So fundus should be firm at or around the umbilicus and midline. It should not be boggy, it should not be deviated, and it should not be above 1 centimeter. Can we do that? Alright, what does the term after pains refer to? Contractions after, yeah. Pain after you deliver. So the uterus will clamp down. It's essentially having mini contractions, which can cause something called after pains. After pains are completely normal, but they are painful. And when they're breastfeeding, it's going to make them worse, because breastfeeding releases natural oxytocin, which is going to cause them to cramp more. But it will help to clamp their uterus down. So after pains, completely normal. We do treat them for pain, but it is normal. Very good, uterus. Moving on to bladder. You want to make sure that they are emptying their bladder properly. So we do count the first 3 voids post-delivery to make sure that their bladder is emptying properly. If we are unsure and we want to do a non-invasive measurement of that, how can we do that? We do a bladder scan, and then we can count them if needed. So they do need to be emptying their bladder, because if their bladder gets full, it causes their uterus to be really right, it causes their bleeding to be worse, and none of those things we want. So make sure they are voiding. Next one down is bowels. We also want to make sure that their bowels are functioning. There can be a lot of trauma to that area, and so we want to make sure that we put them on stool softeners if needed, and make sure that their function has returned. We do try to avoid a lot of straining, because if they have hemorrhoids or they have a bad laceration, that can be painful. So we do give them stool softeners pretty frequently post-delivery. The next one is lochia. The term lochia is just kind of a catch-all term for the normal expected vaginal discharge that you have, and there's 3 different types. So there's lochia rubra, which is the bloody discharge that we see post-delivery. That usually is there for about 2 to 3 days, so usually while they're in the hospital. And then that's going to be followed by serosa, which is the pink tinge that they usually have between 3 and 10 days post-delivery. And then most patients may not even recognize this, but they usually do have some white discharge, which we know is alba. So it should go rubra, serosa, and then alba. What you're going to be dealing with in the hospital is going to be rubra. Let's talk about amounts. We're just going to write the terms down, and we're going to fill them into the right. So there are different amounts of bleeding that you can have, and obviously the nurse is probably going to eyeball it and say that is whatever it is. But for testing purposes, you actually have to have something that's measurable, that you can see, that we can tell you on a test. So here's your measurements. Let's do the terms first. So scant. Y'all want me to do the measurements with it? Is that easier, or do you want me to go back? Okay. Scant is going to be 1 inch on the peripad. Small is going to be 4 inches on the peripad. Moderate is 6 inches. Large is saturating a peripad within 1 hour. And the other one that I usually put in is copious, and there's never any doubt if you have copious bleeding. It's obvious. It's just way too much. So going back to the top, let's talk about what's normal versus abnormal. Scant and small are going to be considered normal for all patients. If they have scantometallochia or scantometal rubra, then that's completely fine. So scant and small are normal. Moderate is that it could be normal, but may not be normal. So let me give you kind of why it would be. If you have a mom and this is her 4th delivery, then moderate is okay. If you have a first-time mom that had a really big baby, then we would tolerate moderate for a period of time. But it is not normal for a first-time mom that's had a normal-sized baby with no type of birth trauma to have a moderate amount of rubra. So moderate is kind of that gray area. It depends on the patient as to whether or not it's normal or abnormal. Large is abnormal for everyone, as is copious. So all of those would require some intervention. Now, if you were to do a patient assessment and you pull back the cover and the peri pad is saturated, what is your follow-up question? How long has this pad been on, right? Because if it's been on for 6 hours, then that is not really what we're considering a large amount of refrux, right? So it is gonna be based on time. The opposite is also true. If you know you put a clean pad on 15 minutes ago and now it's saturated, we're not gonna wait an hour to decide we have a problem. So what we have found is that we are woefully under-treating postpartum hemorrhage. So we used to eyeball it and look at it like, it looks about like 500. We were grossly underestimating how much blood loss we had. So now we actually measure it and do a much more quantitative count so that we can be more aggressive about treating it. Okay?
Right, what were the centimeters in there?
Inches you mean?
Yeah.
Yeah. Scan is 1, small is 4, moderate is 6, and then large is saturated for pad an hour.
This week's plan as well.
You could weigh it, yes, absolutely. 1 equals 1, yeah, and we're gonna practice that too. Alright, next one down is gonna be your episiotomy / perineum. So let's talk about some terms first. What is the difference between an episiotomy and a laceration?
One doctor.
Okay, which one does the doctor cut? Episiotomy. Laceration is a tear. So we kind of gauge them the same way we do 1st through 4th degree, but you're never gonna see a physician cut a 3rd or 4th degree. They may have cut a 2nd degree that tore into a 3rd or 4th degree, but we don't cut 3rd or 4th degree. But we gauge them the same way. So episiotomy is gonna be a surgical cut, a laceration is gonna be a tear of the body with itself. So looking at your degrees, 1st through 4th, so 1st, 2nd, 3rd, 4th. 1st degree is very superficial, it is pretty common, it is fixed, they suture it up, and it heals just fine, no long-term issues. 2nd degree is probably the most common degree of episiotomy that's cut. It is also relatively superficial. It is stitched back together, it heals usually with no issues. So 1st and 2nd degree, common, and no huge long-term issues. The problem that we get into are your 3rd and your 4th degrees. So 3rd degree is gonna be from vaginal opening down to, but not through the rectal sphincter. And it's really hard to describe because you think about distance, but it's not just distance between the 2 openings, it's also depth. So a 3rd degree is a very deep wound. It is a pretty extensive repair they have to do. So if they think it may be a 3rd or 4th degree, they will do a rectal exam at the end to see if the rectal sphincter is intact. If it is, they would call it a 3rd degree. If it is not, it is a 4th degree. So 4th degree is opening to opening, meaning there's a direct pathway from the rectum to the vaginal wall. Both your 3rd and 4th degrees have some long-term issues that can happen. The most common complication, other than the pain of the repair and tearing with a subsequent pregnancy, is going to be fistula formation. So there can be an abnormal pathway that develops between the rectum and the vaginal wall, which can cause a lot of infections and problems. Do you have a question?
Yes, so 4th degree, are they just stitched up right there, or does it require them to go to like OR?
It depends. Usually we can do it in the room as long as they're well controlled. Sometimes for lighting purposes, they'll go to the OR because the lighting is usually better in the OR, but usually we can repair it in the room. Especially if they have an epidural, we'll just go ahead and redose their epidural and get them comfortable, and then put them up in stirrups. We don't typically do that. We usually just hold their legs. So we'll go ahead and put them up in stirrups because those repairs can take anywhere from 45 minutes to a couple hours, depending on how severe and how much suturing they're having to do. There is usually a ton of swelling, and so those patients, we will often put a Foley catheter in so that we can try to get some of the swelling down before, because sometimes it's even problematic from the void because there's just so much swelling. So we don't like to say 3rd and 4th degrees. There's a lot of extra paperwork that we have to do to keep track of those patients. The biggest thing would be just that long-term complication of fistulas and tearing of the next pregnancy. So if you had a mom that had a 4th degree tear of her first baby and the second baby is about the same size, it could even be a discussion of, hey, you want to have a C-section for the second baby. Scar tissue just does not stretch like normal tissue. So once you have a scar there, you're going to have a tendency to tear in that same spot the next time around. Okay? Yes.
So, for the 4th degree tear, do they still stay in the hospital the same amount of time if they didn't tear, or do they stay longer?
As long as there's not any complications that we identify in that postpartum period, they would go home the same time. they're just gonna be walking a little sideways usually for a little bit. It's a very painful, there's a lot of swelling, a lot of pain, yeah. Not anything fun, yeah, for sure. Alright, when you're looking at that incision, you're gonna treat it like any other incision once it is sutured back together. So you can use your normal, whatever you use to assess something, but I'm gonna give you a different acronym, because there's always acronyms. And this one's gonna be REEDA, R-E-E-D-A. So we're gonna assess that, whether it's an episiotomy or a laceration, once it is repaired, we're gonna assess it using the REEDA method. So you're gonna assess it for R, which stands for redness. E stands for edema. The second E stands for ecchymosis or bruising. The D stands for discharge. And the A stands for approximation. Questions about episiotomies or lacerations? The last part of this got cut off, and it is going to be emotional status. And hemorrhoids, I forgot hemorrhoids. Don't forget hemorrhoids. They will remind you. So bubble we've already covered. P is gonna be hemorrhoids for the first one. You're gonna assess to see if they're present, so that we can treat them appropriately. The treatment of choice for hemorrhoids is gonna be the use of witch hazel, which helps them to shrink back down. So we note if they're there, we give them some witch hazel, and they should hopefully shrink up and be much better. Very common. And then the E for key is gonna be emotional status. We're gonna talk about the different normal findings that we see in that immediate postpartum period. So there's 3 phases that a woman usually goes through in that immediate postpartum period. The first one is taking in. And this is where they want to relive their birth experience. They're fine with others doing for the baby. That's completely normal. So taking in. So immediately in that postpartum period, they may let others kind of hold and care for the baby, and they want to tell you all about their birth experience. So just let them. The second phase is going to be taking hold, and this is where they start to care for the newborn. The key here is to be very encouraging. If they put the diaper on backwards, no big deal. We just go over how to diaper the baby. If they say they suck at swaddling, then we just show them how to do it and keep on going. Lots of encouragement, because this is going to be a lot of new information that they are getting, so very encouraging. And then the last phase is letting go, and this is usually seen once they go home, when they start to figure things out and they've reordered their life and they've incorporated the baby into it. So that usually happens more when they get home and they can get their own routine. So taking in, taking hold, letting go. What are some ways that if I'm the nurse and I'm looking at a patient that has a newborn, how am I gonna know if that mom is bonding with that baby? Talking to the baby, caring for the baby, holding the baby. In-face holding is very important. Are they looking at the baby as they're caring for the baby? So very important that we do see bonding taking place. If we do not, then we would encourage that, but if we're not seeing adequate bonding, that may be a reason that we need to get social services involved, to make sure that we have adequate resources and all the things that they might need when they go home. Alright, the parts of this assessment that you will do on that schedule of Q15, Q30. The uterus, the rubra or lochia, and the perineum, along with vital signs. The other stuff we're going to do less frequently. So uterus, perineum, lochia, and vital signs are going to be part of that Q15, Q30, Q1 hour. Why do you think we check it so frequently? Yeah, because if they're going to have a postpartum hemorrhage, or if something is going to go really bad, it usually happens pretty quickly after delivery. Alright, I'm going to do a couple more slides just to kind of, or one more slide to show you all pictures of what we just talked about, and then I'll be over. Alright, left hand side just shows you the amounts we've already talked about for testing purposes. I'm not going to plop a Gary pad down on the desk and be like, how much bleeding they got? So we will go by the measurements, so just kinda keep that in mind. In the hospital, the nurse is gonna go, how much bleeding you got, and you're just gonna look at it, we're not gonna measure it, but for testing purposes, we will go with that. The one at the top is 2 different types of episiotomies. It's not my preference, it's physician preference, but I want y'all to see there are 2 different types. So there is a midline episiotomy, which is straight down, which is more common. And then some of your physicians will do a medial lateral, which is cut from the middle towards the side. We just document whichever one they perform.
I can make a lateral prevent, like, the third and fourth block.
It's not gonna tear. I will say it's a little bit worse healing process. It hurts a little bit more to do a medial lateral, but you don't have the tearing into the rectum, so it's a trade-off. Most of your physicians cut straight down the middle there. Okay. And then you have your degrees at the bottom, so 1st through 4th. I will show y'all in SimLab, because that does not do it justice, so that you can see that it is a deep wound, because it just kind of doesn't make sense in a picture, but once you see it, you're like, oh, okay, that makes sense. Okay. All right, so we're gonna pick back up with Reese, so why don't y'all take about a 10-minute break, stretch your legs, get you some caffeine if you need to, and then we will apply some of the